It's really a privilege and an honor to get to come and speak to you. If any of you know Dr. Kim Riddell, she was probably instrumental in my being invited over here. Standard, we have some objectives for today, but if you want to look at those, I'll give you a bit of perspective. First off, how many of you are clinicians who see patients and order lab tests? So we've got a couple, not that many. And most of you then are in the laboratory medicine field doing lab tests, reporting on them. Okay. So, so that's good to know, because what I'm going to try to give you is my perspective as someone who both practices and tries to help guide practitioners, mainly primary care practitioners, but hopefully the way that I approach this and the sort of template for approaching this kind of decision. When do we change as a clinician to using a new diagnostic strategy? When you're at my stage of my career, patient presents, I've got a kind of a template in mind of how I'm going to work them up. When do I adopt a new test? And when do I stick with the old? And so that's the perspective that I'm presenting today. If there's time, I'll be happy to entertain questions about the Health Technology Clinical Committee. That's a part of my work now that I really am enjoying and finding fascinating. But that's not going to be a major focus of this talk unless there's interaction that I bring to that in that role. Just the other caveat, I work for group health. I'm both a practicing physician and have an administrative role there, but these remarks are not necessarily represent the views of group health. Well, what's our goal? When a patient comes to us, we need to make a diagnosis. Why do we bother? Well, there's one overriding concern that I think if we keep our focus on as clinicians, it ultimately everything leads to this and hopefully flows from that. We want to improve the patient outcome. That's the fundamental thing, why we do anything we do in medicine. And there are kind of two major aspects to that. One is to correctly diagnose the cause of a patient's disease. And I'm highlighting here dis-ease. The patient feels bad. They have symptoms. They don't feel well. And we want to pin down what's making them feel badly so that we can make them better. Another time where we use diagnostic tests is when the patient feels just fine, thank you, but we're maybe doing a screening test. So we're seeking early diagnosis before symptoms ever develop. And I'm just going to digress just slightly. In my perspective, this is an area where enormous caution needs to be taken as clinicians, because this is where more than anything the ethical dictum of primum non nocere, first do no harm, is really critical. And in my view, we should be using diagnostic tests in the screening role only when patient outcomes have been established as improved with the screening. And I just want to give a brief example. Ovarian cancer screening is an area of some controversy, and I did a little searching, and there's an organization called the National Ovarian Cancer Coalition. They have a statement that although there is no consistently reliable screening test to detect ovarian cancer, the following tests are available and should be offered to women. So presumably all women, but especially those at high risk. And then they cite pelvic exams, ultrasonography, and the CA-125 test. Well, what does the evidence that is available to us say? Well, in the British Journal of Obstetrics and Gynecology, they did a study and said their conclusions were that ovarian cancer screening using annual transvaginal ultrasonography and annual CA-125 is not a safe alternative to prophylactic surgery in women at high risk of developing ovarian cancer. It does not detect early stage tumors in premenopausal women, and there is a high rate of false positive results. So just to briefly review some of what they found. In this study, they screened 341 women. 179 of them were deemed to be at high risk of ovarian cancer. They could have family history, things like that. Out of these 341 women, 4 ultimately were found to have ovarian cancer, but only 1 of them was identified in the screening process. The person who had their cancer detected through screening already had advanced cancer. It was not captured at an early stage. And this person, despite the screening, despite having her cancer diagnosed when she was asymptomatic, died 18 months after she was diagnosed. To get to surgery to that one woman, they found enough abnormalities in their screening process that 30 women underwent surgery. So the screening process in this study produced at least 30 surgeries. There were no ovarian cancer deaths prevented, no identification of early stage ovarian cancer, highlighting why they are concluding that actually at this point in time the best evidence says that doing this kind of diagnostic testing to screen for ovarian cancer is likely to produce more harm than benefit. We're more likely to harm our patients than help them. I think it's, just want to make sure, probably this is all old school, so I'm just going to kind of rush through this, but I want to make sure that we're talking on the same page. Since I knew this was a lab medicine grand rounds, I thought I'd address what sometimes is called analytical sensitivity and specificity. This was almost more for clinicians, but sensitivity and specificity of diagnostic tests can have at least 2 meanings. In this case, it's you're testing for something, and does your test identify what it is you're testing for, whether it's albumin in the serum or glucose or whatever. In this case, the sensitivity, if your product is present and your test is positive, you're in cell A. If your product is present, but your test says it isn't, you're in cell C. And your sensitivity is how many true positives do you have when the product is actually present. Specificity is sort of the opposite. If your test says it's negative, is it truly absent? Or are there times where you have false positives where your test says it's there, but it's absent? And then there's the concept of clinical sensitivity and specificity, which as a clinician is what we mostly hear about. And this is if you have the disease. For example, if you have ovarian cancer and you have a positive test, that's a true positive, but often you'll have a negative test. So your test says you don't have the disease, but you do. And your sensitivity clinically is the proportion of positive tests as the numerator, but your denominator is all the people with the disease. So those who have a true positive and also a false negative. That's your denominator for determining clinical sensitivity. Specificity is just the converse. Negative test, when disease is not there, the more of those you have relative to false positive tests, which is cell B here, then the better your specificity. And of course, as clinicians, if we knew whether the disease was present or absent, we wouldn't even need to do the test. We're actually not going down the columns, we're going across. And so we're more interested in the positive predictive value. So if you have a positive test, what's the likelihood that you have the disease as compared to having a false positive test, where your test is positive, disease is absent, and you've got a false positive. The more true positives you have relative to false positives, the higher your positive predictive value. So it's really, in some ways, it's pretty simple. When should a clinician adopt a new diagnostic test? When it's a better test. Well, what are the things, from my perspective, that make it a better test? Well, again, the key, if you can get to that information, is that patient outcomes are improved by using the new test instead of the old. Some signs that it might be a better test is being more accurate, being cost effective, being maybe not necessarily any more accurate. It's cost effective enough, but it's simpler. A simpler test is often going to be better in clinical practice than a more difficult test. this may be a little bit where some overlap comes, at least in my thinking. This is a slide taken from a paper published in the British Medical Journal. And I found that in my practice, this kind of gave me a way of putting some clarity into a kind of thinking that I think clinicians sometimes do, but when you do it more explicitly, it works better. And basically, you can take any kind of intervention. It can be a diagnostic test, it can be a treatment. And you can create a matrix, and more or less, if you dig, you can put it into one of several cells. So as you go across in this example, if your intervention is more effective, so in the case of a diagnostic test, if it's more accurate, if it gives you a more accurate result, then that's going to be somewhere here in column 1. Column 2 is equivalent accuracy. Column 3 would be it's less accurate. And then you can go across in rows. Row A is things that cost less. Row C is those that cost more, and row B are neutral. So if you have a diagnostic test that is more accurate and actually costs less to run than your old one, you're up here in cell 1A. That is nirvana. You get a better test at less cost. That's a perfect outcome. And that's green if the colors show up, meaning, yes, change. Go ahead and do that test. Over here you have an equivalent accuracy test, but it costs less. You're up in the upper row. So same accuracy, lower cost, that's another bingo. And over here, cell 1B, it's equivalent cost, but it's more accurate. So basically you have 3 cases where if you can identify it as that, that's a no-brainer, go ahead and do it. You have the opposite over here where it's less effective, the worst is down here, less effective, higher cost, test shouldn't be adopted. These are the challenging cells. This is the one where a lot of new technologies are. Cell 1C. It costs more, but it's also more effective. Well, what if it's slightly more effective, but it costs a gigantic amount more? That's maybe an easier decision. Maybe an easy decision when it only costs a little more and it's a lot more effective. But that's where a lot of challenge is faced in the way we decide things about medical care, especially with medical care costs going up and up and up and up and up. So as I started to prepare this talk, I thought, well, what's a case study from my own practice where there's a new test that has come along, and I've been trying to decide, is it a better test? Should I keep doing it the old way? Should I switch to the new way? And so this example is one that I'm speaking mainly from my own practice, but it's one that I've followed all along. And it's basically comparing a new way of doing pap smears, different names, liquid-based cytology, thin prep, thin layer pap smears, but I'm abbreviating it as TLP for thin layer pap, or conventional cytology. Well, back in 2003, a not University of Washington, Dr. LeMay, published a study in Archives of Pathology and Lab Medicine. And basically what they did is they had a bunch of patients who got conventional pap smears in their lab, and they got a bunch that got the newer thin layer pap smear. And they looked at how many positive tests did they get with either one, and they discovered that there were a lot more positive tests using the thin layer pap. And in the conclusions of the paper, Dr. LeMay and I think it's her colleagues, reported out that their findings strongly support thin layer paps as a superior screening test. And many of you probably know that it's become more and more common and may actually be the most common way that pap smears are done today. Well, is it a better test? And from an evidence-based perspective now, there are really, if you're a clinician, there are really 3 key questions that before you want to adopt a new test as a better test, you want the answer to all 3 of these to be yes. So you're reading a paper like Dr. LeMay's paper, and you want to ask yourself, is this research enough to tip me? Is it a tipping point for me to start adopting the new test? And number 1 is, did the clinicians using the new test and the old face diagnostic uncertainty? Okay, some audience participation. One of these patients has a basal cell cancer. How many of you think it's this patient? And how many of you think it's this patient? Some people still can't tell. Well, it's obviously the patient in the lower right. You don't need much of a diagnostic test to distinguish between those two cases. Now, as new tests are being developed, typically the early reports do report what is the test performance in patients known to have the disease and what is it in those known not to. Certainly, if you have a test that can't distinguish basal cell cancer between these two, it's a pretty lousy test. So that's kind of a first step. But it doesn't help you as a clinician. Okay. Again, some audience participation. This would be real simple. This patient either has psoriasis or a fungus infection of their nail, or they have squamous cell cancer. How many of you don't know what this patient has? We don't know. We need a good diagnostic test in this case. We have diagnostic uncertainty. And what we want to know before we adopt a test is, how does the test help us in cases like this? Not the ones like the previous example where it's very obvious what the patient has. The right kinds of papers that study a test in patients who have different presentations of the disease, who have illnesses, whose symptoms overlap, etc., they're going to avoid something called spectrum bias. Spectrum bias is the concept that tests perform differently in patients with different levels of disease. The more advanced the disease, the more likely the test is to give you an accurate result. The less advanced, the more likely it is to be wrong. And if you have diagnostic uncertainty in the population that you study, then you avoid that bias. So this study actually passed that particular criterion. People came in for pap smears, their clinician didn't know if they had cervical neoplasia or not, and they did the test. This is, in my opinion, the most important criterion. Was there a blind comparison with an independent gold standard applied similarly to the new test and the standard test? Hopefully applied to everyone that you're comparing the tests with. But sometimes that's impossible. Pap smears, it can be very difficult to do that. And in the LeMay study, again, they basically just looked at their positive and negative rate in people who got either a conventional pap or a thin layer pap. So this criterion was not met. And in fact, that makes the study inadequate to tell whether this is a more accurate test or not. Because we don't know. Yeah, there were more positive tests. Were they true positives? Were they false positives? Was the positive predictive value better or worse? You can't really say when you don't compare to the gold standard. And the third key criterion is, did the results of the test being evaluated, in this case we're evaluating thin layer paps, influence your decision to carry out the gold standard? If the results of the test you're studying determine whether or not you do the gold standard, you pretty much always get an overestimate of the sensitivity of the test, and sometimes you'll get an overestimate of the specificity. And again, a nota bene, overestimated, because if you don't do the gold standard in everyone, you can't determine what the sensitivity and specificity is. You can only make an estimate. You can only take some sort of a guess. Okay, last audience participation. Imagine you're at the audience for Who Wants to Be a Millionaire? And Meredith Vieira is asking the question, and the person says, I need to ask the audience. So the question that the person has to answer is, what is the sensitivity of a PSA, a prostate-specific antigen test, of 2.6 or higher for prostate cancer in men who are 55 years of age or older? So out of 100 men who, it turns out, actually do have prostate cancer, how many of those 100 men are going to have a PSA of 2.6 or higher and they have prostate cancer? It's going to be 5 answers. We'll poll the audience and we'll see if our contestant gets to win $1 million. Okay. The answers are 20, 40, 60, 80, and 95. How many of you think that the sensitivity of a PSA for prostate cancer is 2.6 or higher? Any takers there? We've got a couple who are thinking maybe. Okay. How many of you think it's 40%? Okay. We've got a few. 60% sensitivity for prostate cancer. 40 has a few more. 80% for this level. Okay, about as much as 40. And how many of you think it's real sensitive at that level? We've got one. Okay. So congratulations to those who took the two ends, because it gets kind of crazy to stand out like that. Here's my first comment. We now know the answer to this. And yet, I mean, I'm not expecting everyone to do this, because y'all don't, screen men for prostate cancer necessarily, et cetera. It's not part of your routine practice. But it's interesting. We had people who took every single one of these. We had people who think the sensitivity is really quite low, and at least one person who thought sensitivity was really very good, and quite a few people who thought it was awfully good, and so on. And I think that's a really kind of interesting observation about what we know about diagnostic tests. If sensitivity and specificity matters for something as common as this, it's intriguing. Now, hopefully, it might be a little different in a room of clinicians, especially people who care for men over 65. But here's the answer. It's 40%. Why do we know that? Well, they did a study a few years ago, and they took several thousand men, and they randomized them to either get a placebo or finasteride. And they followed them up for 7 years, and the idea was, does this prevent prostate cancer or not? And when you entered the study, the expectation is that at the end of the study, you were going to get a biopsy of your prostate. So they ended up biopsying over 5,000 men who took placebo. So their PSA wasn't influenced by the drug or anything. This was just their natural PSA. All of them got a prostate biopsy. They all got the gold standard. You didn't know for sure, did they have prostate cancer or not? And they all had a PSA within at least a year. If their PSA was longer than that. And it turns out that 60% of men with prostate cancer, if you go and do biopsies, have a PSA of 2.5 or lower. It's actually 17% of men with prostate cancer that you can find on a biopsy have a PSA of 1 or less. So this is not a very sensitive test. At a cutoff of 4, which is where we often and traditionally have used the cutoff, it's 20%. It is 20%. So the point there is just that until you do the gold standard on everybody, you can get incorrect results telling you what the sensitivity and what the specificity is. So you're just kind of flying blindly when you're really trying to figure out how accurate is the diagnostic test I'm doing. And this particular LeMay study failed that criterion. Whether or not someone got colposcopy and biopsy, in that case, depended entirely on what the results of their screening test were. So I'm going to briefly just touch on these. These are 4 additional points. If you're an evidence-based master, you might go beyond those 3. But if you just focus on those 3 criterion, those are really the critical ones. In my practice setting, will the test be reproducible and will the interpretation be satisfactory? An example I thought of here is I order MRIs sometimes for people with back pain. If I had to interpret them, it'd be a waste to order an MRI because I'm not good at that. But luckily, there are radiologists who are. Are the results applicable to patients in my practice? Sometimes I'll see studies done in Sri Lanka or Bangladesh, if you read some of the British journals, et cetera. Very questionable whether those patients are going to match the patients that I see in Spokane. The other 3 really are coming back to the key questions about, is it going to even change my management? What are we going to do different depending on whether the test is positive or negative? And ultimately, will doing this test make my patient better off in terms of patient-oriented endpoints that really matter? So, the same year that Dr. LeMay published his study, there was a study published in the British Medical Journal. And in this study, every woman, they had actually two populations they looked at. One was women who had been referred in for a colposcopy. They'd had some sort of abnormal test or finding or something. And before they did the colposcopy, they did both a conventional Pap and a thin layer Pap. And then they also had a larger population of nearly 2,000 women who were just getting screening Paps. But all of them agreed before to enter into the study and to go on and get a colposcopy, and if a colposcopy showed something, get a biopsy. So every single person got one. But again, there was diagnostic uncertainty. One population, they were referred in for a definitive test because they didn't know for sure if they had cervical neoplasia or not. And the other larger group was women just being screened and you didn't know. As I mentioned, every woman in the cost study got both a thin layer Pap and a conventional Pap and got the gold standard. And as is the case, when that's the case, whether or not the gold standard was done did not depend on the results of the test. And what did the cost study show? Well, actually, the conventional Pap was more sensitive of women who, and they basically reported out their results in the colposcopy arm and the screening arm. And since I'm a primary care doc, I'm presenting the results from the screening arm, but the colposcopy arm had quantitatively different but qualitatively similar results. Conventional Pap smear was actually more sensitive. There were more cases of cervical neoplasia who had positive conventional Paps than thin layers. It was also more specific. If a woman did not have cervical neoplasia, she was more likely to have a negative test. There were fewer false positive tests. There were more true positive tests. So if you look down here, the converse is also true. If there's more true positive tests, there's fewer false positives. And then if you total up all the results where if it was negative, you didn't have CIN. If it was positive, you did. Total up the whole accuracy. The conventional Pap, for every 1,000 women screened, at least 30 women got an accurate test result on conventional Pap that if they had undergone thin layer Pap, they would have got an error result. It either would have said they could have had CIN and been wrong, or said they didn't have CIN and that was wrong. So if we go back to this matrix that I like to use, and I think is something that would be good for us to think about, both in deciding whether to cover testing, whether to do testing, whether to offer testing. Conventional Pap, in this study at least, was more accurate. So it's over here. And it turns out that a conventional Pap costs less than a thin layer Pap. So we're up here. We're in the nirvana zone, at least for these two tests. So at that point, it was clear to me that it was not time to adopt a thin layer Pap. I thought I'd finish by just saying, okay, well, this is not only Budenholzer from the outskirts of Spokane. This is from an editorial published just last year in the Journal of Obstetrics and Gynecology. I understand Dr. Grossman talked to you all about the U.S. Preventive Services Task Force. Dr. George Sawaya is on that task force. He's in the Department of OBGYN at UC San Francisco, and he was asked to publish an editorial when that journal published a study that Arbin et al. Did. And you can read along, you can close your eyes, whatever, but I'm just going to quote it. The evidence about the accuracy of liquid-based cytology compared to conventional cytology, and the results are not encouraging. So this is 5 years after the cost study. In summary, best evidence suggests that liquid-based cytology does not lead to more disease detection. So liquid-based cytology is not more sensitive, but it appears to increase the false positive testing, so you get more false positive results. Sobering news, says Dr. Sawaya, given that over 80% of U.S. OBGYN surveyed use thin layer cytology. He then refers to a randomized trial done in Italy that he says deserves attention. in their colposcopy was performed in all women. Women were randomized. In this group, about 22,000 plus got thin layer PAP, 22,000 plus got conventional PAPs. So this was really looking more at outcomes. But comparing these techniques head-to-head, two important clinical questions were answered. First, liquid-based tests were more likely to be interpreted as abnormal and equivocal, but despite the more positive tests, it did not lead to detection of more high-grade cervical neoplasia. In other words, the extra positive tests appeared to be false positives. So you got more positives like LeMay reported, but you got more positives because basically you got false positives instead of true positives. He says we should seriously question the balance of benefits and harms of liquid-based cytology, especially in women in younger age groups, because the equivocal diagnoses are doubled, and then these are groups who have high rates of positivity for HPV, so they have a thin layer PAP, they get a reflex HPV, it's positive, they go on and get colposcopy, but there's no real benefit to them. Patient outcomes are not improved because this test isn't really detecting more important high-grade disease. As advocates for best practices in women's health, he says, we must simply be more skeptical about claims of superiority of new tests and treatments. Such claims are often based on flawed scientific methodology and amount to little more than advertising. I was running through these slides, and Dr. Astian was up here, and here comes the slide with Dr. LeMay's name, and he says, oh, is that Dr. LeMay here? And I said, oh, I hope not. So we looked, and the Dr. LeMay who published this actually works for Quest Diagnostics, a lab that makes money by getting people to come in. So they got their study published in a reputable journal. Lots of women, there's thousands of women, and probably were part of what has moved the curve, the tipping point for what is actually used. So if we're going to be more successful skeptics, how do we do that? Well, basically know the three criteria. We're coming back to our objectives for the talk. The three criteria that need to be met that a clinical study is valid and reliable. Were the patients included in the study? Was there diagnostic uncertainty? Did it evaluate a spectrum of disease? Was the gold standard for diagnosis applied to all the patients in the study? And did the test results influence whether or not the gold standard test was done? And what we want is a study in which they got the gold standard regardless of the study in question. And if we can, our goal again is the patient better off for having had the test? If so, then we should adopt the test. If not, we should probably wait until a better test comes along and keep doing what we're doing. It isn't what we don't know that gives us trouble, said Will Rogers. It's what we know that ain't so. So thank you very much. If there are questions, I'd be happy to answer any questions. Yes?
Is Dr. LeMay the one that measures vitamin D?
Good question. I don't know. I don't know. Good question, though. That is interesting. At Group Health there in Spokane, there's sort of a cadre of some of our clinicians who are really big now on screening with vitamin D, ordering vitamin D, convinced of its benefit. And as you might expect, I'm kind of holding the line on that at this point. Any other questions? Yes, sir.
I just asked you to repeat it for the audience.
Thank you.
You're the second or third person I've heard say that PSA is not helpful, or at least that's a synthesis of what's being said. But there's a fair amount of literature on the rate of change of PSA as being a useful thing to follow. And if you do that, then you'd have to do the test fairly often. You know anything about that, if that's been studied further?
Okay. So the question is, I talked about PSA testing with the suggestion that it's not very useful as a screening test, but is the rate of change of PSA, instead of just measuring a simple PSA level, going to produce benefit, whereas making decisions based on a simple PSA level maybe not so helpful. two comments. One is just a protective comment, so to speak. I have my views about whether PSA testing should be offered or not, but the main point of bringing it up here is really twofold. One, to show that when you actually do a test and evaluate its test characteristics properly, you can get results that are very different than what you might expect or that what's been reported. There are studies that report out sensitivity and specificity of PSA with much more impressive results for it, but they did not apply the gold standard to all people. So we didn't really know what the sensitivity and specificity was. So the point of that little digression was mainly to point out that you can get an accurate result for sensitivity and specificity only when you do the gold standard in all cases. What I would say about the rate of change is essentially what the essence of analysis here is. Well, let's find out if the rate of change, what is the sensitivity and specificity of the rate of change of PSA for prostate cancer, just to find out what its diagnostic test characteristics are. I would argue that we don't know because I don't know of any study where they looked at that and then did biopsies on people. Now, maybe they have data from this prostate cancer prevention trial that I've not seen published yet that talks about that. But when it comes to screening, I really am convinced that you first need to do a randomized trial. Otherwise, you get various kinds of biases built in, and it's hard to really know if patient outcomes are improved if you don't randomize people to screening or no screening and then look at their outcomes. And at least for me in my practice and my decision for me, I'm 54 now, I haven't had a PSA test. Currently, I'm not planning on getting one. I order a few for my patients. I try to give them informed consent, and if they still feel like it's something that they prefer to do, I definitely order it. But in my view, it's not established that that gives better outcomes, and so I would not argue that it's going to improve things. Implicit, though, in that whole discussion is, hey, if we need to look at that, it sort of says, well, just ordering PSAs and using those levels as decision makers maybe isn't so good. Anyway, now we've got lots of questions. So let's go here, and then we'll go way in the back and then up here.
I'm wondering if you could comment on whether group health has any institutional mechanism for evaluating evidence on test performance, whether, how it makes those, if it does that, how it makes those recommendations known to its practitioners, and whether there's any mechanism for tracking whether people actually follow those recommendations.
I know that it's done on a sort of on an as-needed basis, but when things come up, when things become clear that tests are being ordered, et cetera, then it can collect people who can evaluate this, use evidence-based methods, and then make recommendations. Tracking it, there's only so many things they can track, and if it's an important thing, and importance can be based on many different factors, then there are now with the electronic medical records and so on some pretty robust systems, so we can track people's LDL levels and hemoglobin A1Cs, et cetera. But for just the whole battery of all the tests, it's not necessarily routinely done. But if necessary, it comes up. In the back
Yeah,
there.
I like your sort of 9-box analysis very, very well. But what about the situation if there's a new test and there has never been a test for that particular entity before? So in other words, it's either, in other words, you don't have something to compare it to in terms of testing, and how would you go about that? An example would be a lot of the new DNA-based tests where we can detect some disease that we couldn't, or disease predisposition that we couldn't detect before.
Yeah, that's an area where I'm frankly sort of studying and trying to learn in some ways because it is new territory. I think it's an area. Why? So I have to first say I don't know. I don't know exactly. But if there's never been a test, then I think what the way I would sort of approach it at first is try to identify. This would be a case where you definitely would want to get people who you know have the disease, and often it is a fairly rare disease, and people that you're pretty sure don't, but if you can, some sort of overlap, and then at least study the test and see how does it perform in those two, because it's hard to do a cohort study and do gold standards, especially if it's a rare disease. And you can at least identify from the clinical phenotype, if you will, how sensitive is the test, how specific is the test, when you have a clinical phenotype that you know has the disease and one that you're confident doesn't. So that would be my first approach. And the thing that I find sort of interesting, and I don't know whether I find it scary or not, I just noticed I just got my first newborn screening panel back that now includes testing for cystic fibrosis in newborns. Well, I don't know how many of you know this, but in some states they did some pilot studies. They tested a bunch of newborns for cystic fibrosis, found that genetically they had it, which means, of course, their mother had it. But their mother didn't have cystic fibrosis, but she had the genes. But she was absolutely 100% healthy, no clinical phenotype of CF at all. And so that kind of makes me a little nervous, at least from the standpoint of how often, if we develop a new genetic test and that becomes the gold standard, how often is it going to tell us you have a disease when in fact you really may never have any clinical manifestations? So I don't know, it's an area of a lot of development. I don't know the exact answers, but I do think that if there's no test that's ever been done before, you at least need to look at it in those who clinically have the disease and those who clinically don't.
That situation, moms are carriers, so she's not going to phenotype.
Well, they have found cases where the mom is a homozygote. I mean, yeah. She has two genes for CF, and yet she's clinically well and delivered a baby, had no problems. Nobody ever suspected any clue, and they, So the point is, genotype, at least in some diseases, doesn't necessarily produce phenotype. Now, in some it presumably does, Huntington's disease and some others. But I think the thing that clinicians are going to have to really struggle with in genetics is single nucleotide polymorphism changes, et cetera, where, okay, maybe your risk of heart disease at this point in your life over the next 5 years is 5%, and you get this genetic test, and it increases your risk by 1.2. So now instead of 5%, it's 6.5%. What difference does that make? Especially, it may or may not improve outcomes, but it's almost certainly going to be in this row for cost. It's going to probably be very expensive.
Can you comment on situations where the biological gold standard that you were positing is not necessarily perfectly correlated with patient outcome? I mean, great example is PSA, right, where biopsy 5,000 men, certainly they're not all going to die of that prostate cancer.
Right.
And this comes up in other situations. So how do you actually extrapolate to your final question, which is, would we improve actual patient outcome?
Well, from my view, practicing evidence-based medicine, and as a clinician, that's why I think it's to me, you start with what's your goal in this patient, okay? My goal, if someone comes to me with symptoms, is to make the diagnosis. And there, the role of diagnostic testing is different than if a healthy patient comes to me and says, my wife says I need a PSA test. I feel great. And then I'm asking myself, well, if I do this, I'm going to make you better off, worse off, whatever. And then there's the whole politics of it and the approach of all the different specialty societies, et cetera. So I don't know if this is exactly what you're asking. The question was, when does, we'll repeat it so I can repeat it for the...
Well, the issue is you posited a biological gold standard. You do 6 or 12 biopsies on this prostate and you find cancer somewhere.
Okay.
But in fact, that's not really what you want to know. You want to know who's going to die of prostate cancer. So
Yeah.
the study, if you could have done it, would have been, I'm going to do this in all these 5,000 men, and then can I actually prevent deaths? Much more difficult, impossible studies.
So
to
the
do.
gold standard
So how
in
do you extrapolate?
the gold standard in the prostate cancer prevention trial was doing a biopsy and then histologically and so on you could identify prostate cancer. But a lot of those prostate cancers would be sleeping dogs that if you never did anything, the person would have not died from them or suffered from them or whatever. And how do you account for that? That is a huge challenge, especially if you focus in on prostate cancer, because even in the study, there's one really good study from Sweden that talked about radical prostatectomy for early stage prostate cancer, but it wasn't a screening population, versus watchful waiting. And after 12 years, with a number needed to treat of 20, so only 1 out of 20 people were helped by radical prostatectomy, they did show some prostate cancer mortality reduction. I don't want to go into the whole study we probably should talk after later. But the point is that there's a lot of prostate cancer, and even then the majority of people never died of prostate cancer. And these are people who somehow had it clinically manifest because they weren't detected by screening or whatever. If somebody can ever come up with a laboratory test that says your prostate cancer is going to progress and kill you, man, they deserve the Nobel Prize, because that is a really challenging question. And where I find it challenging, one of the reasons why I'm not yet, I mean, if the randomized trials say that PSA screening is beneficial, then I'll have to really rethink. But why I'm not a strong proponent of PSA screening is because you definitely do detect more disease. Definitely some, and maybe a lot of that disease would never have caused trouble, but our treatments nearly always at least cause temporary trouble and often cause permanent trouble. If we could, however, identify prostate cancer that was going to biologically behave badly, and we could show that we had a really good intervention for that, then that changes the whole ballgame. But so from my perspective, what you have to do in those cases is look for studies and hope for and ask for studies that compare outcomes with your testing or not. I don't know how satisfactory that answer is, but that's the best I can come up with. Let's go there and then there.
Getting back to the cervical cytology, that's interesting. It's the first time I've heard that conventional cytology actually might outperform thin layer. But two questions. First is, what are people doing at group health in general? And the second question being, in the setting of trials where you're assessing thin layer versus conventional, presumably people might be trained to perform good smears. And one of the issues with conventional, at least in my experience, is that there's always not necessarily good preparation, whereas with thin layer it's more standardized, it's more idiot-proof. So there may be some bias there in the studies. I'm not sure how they were done, so maybe you can address that.
Well, the first question, that's one of the reasons why I sort of had to put the caveat. In Eastern Washington, where we use a contract lab, I'm still doing conventional pap smears and haven't personally been given any real flack about it. For a variety of different reasons, and some of them, basically what I've been told, focus on practicalities of getting cytotechnicians and so on. I'm pretty sure that on the west side of the state here in Seattle, that group health has pretty much moved almost entirely to thin layer cytology. And I think that's one of the things Dr. Sawaya is concerned about in his editorial. In fact, at one point he talks about the fact that, look, I've read him in the past, and at one time he was a proponent of thin layer PAPs, and I think he's kind of moved the other direction. And I think he's sort of decrying a little bit that non-clinical reasons have led to probably its demise. In the randomized trials, they do show a modest benefit in terms of fewer slides needing to be repeated or smears needing to be repeated, et cetera. You asked the question about difficult preparations of the slides. But it's a pretty small number, and in my view, it's like 1% or less of all the women that are analyzed. And in my view, unless you could show that you were actually in the in the lower cost group, that's not a patient-oriented endpoint that matters in the sense of 1% maybe needing repeat pap smears, you're unlikely to result in cervical cancer deaths, et cetera. So, I mean, in my view, right now, there isn't a major reason to make a change. And personally, as long as I can, until I see better evidence that they've improved thin layer PAPs, I currently intend to keep doing conventional PAPs. Yes?
I wanted to ask a different question. So PSA is a good example of sort of a guideline-driven testing algorithm. We always trust our specialists to come up with guidelines. Neurologists have to do PSA. Estimated glomerular filtration rate is one that the nephrologists have decided is a good idea and have suggested they've put out guidelines that we should be using in the EGFR screening modality. What you're suggesting actually is tossing the guidelines aside and sort of taking this on. Every individual practitioner needs to think about the testing algorithms themselves, which seems to me a lot of work. So how do you decide the very first moment to sort of throw the guidelines aside and focus on this the 9-square approach?
So as I understand the question, there are guidelines about testing, for example, PSA, there are guidelines that call for PSA screening for prostate cancer. You also alluded to guidelines coming from nephrologists about, I guess it's using serum creatinines and other factors to estimate glomerular filtration rate. And if, for example, in the case of PSA, tossing the guidelines aside. Well, in years ago, when I first became excited about evidence-based medicine and started practicing it and have never had the slightest urge to abandon it, maybe that's just my quantitative nature or maybe my personality. Certain things that are really common, like for a family doctor, 55-year-old men coming in for checkups is really common. So I would like a world where people were coming out of their medical training and they had the basic skills to do some simple evidence-based medicine analysis and determine are guidelines correct or not. But I've come to believe that's probably a dream world. On the other hand, there are always conflicting guidelines. And if, for example, everyone followed the guidelines of the United States Preventive Services Task Force, which uses an explicit evidence-based medicine approach, they talk about their evidence, they grade their evidence. If we looked for guidelines that reviewed that and basically, took on in terms of, well, what would the guideline have to say that would be the tipping point for changing practice? What I would argue is that if they use an explicit evidence-based process and the recommendations they make are explicitly supported by evidence of improved patient benefit, then that would be a pretty good reason to adopt that intervention. So I can't comment about the estimated glomerular filtration rate. But on PSA, I would argue that if everyone in America followed the U.S. Preventive Services Task Force, we'd still be more or less waiting for the randomized trials to complete, and you guys would be doing a lot less PSA testing in your core laboratory.
Any more questions? Or maybe Dr. Budenholzer will stay for a couple minutes if you have an individual question. Otherwise, I want to thank him.